Good morning, everyone, and welcome to the Friday academic presentation for today. Today's talk is from the Division of Geriatric Medicine, and it's my pleasure to invite our speaker, Dr. Lara Greenstein. Lara is not only the head of geriatric medicine at Helen Joseph Hospital, she is also leading palliative care services. Lara is a wonderful speaker and has a unique skill to tackle simplify complex scenarios that you're likely to meet in geriatric population. So she'll be discussing a very important and challenging topic of managing swallowing difficulties in advanced or in patients with advanced dementia. Lara?
Thanks so much, Anu. So I've chosen this topic today because apart from getting consults for the general geriatric syndromes like falling and dementia, the majority of my work revolves around telling people whether they should or shouldn't be on warfarin, or whether the doctor should or shouldn't insert a feeding tube. So today we'll discuss feeding tubes. So the talk is entitled To Tube or Not to Tube, and thank you so much everyone for joining. So I thought we would start off with a case presentation just to make the topic a little bit more personable. So we'll start with our patient, who's Mrs. LT. She's an 85-year-old female who lives with her daughter, and in 2015 she had a stroke which left her with the left hemiparesis. She's got background hypertension and type 2 diabetes. And then in 2016, she was diagnosed with vascular dementia. At that point, she was able to do activities of daily living relatively independently. Her daughter helped her with instrumental activities of daily living, but as her dementia progressed and she became more severe, the less she was able to do. And then eventually in 2021, she became bedridden. That's where we met her. She comes into our hospital and when she was quite short of breath and delirious, and she was admitted with a pneumonia. She also had a grade 2 sacral bed sore, which just shows us that she's been lying in bed for quite a long time. Right, so in view of the patient's frailty and baseline, an aspiration pneumonia was considered very likely. Because of this, speech therapy was consulted for a swallowing assessment, and they confirmed aspiration. She had an NG tube inserted, and after 2 weeks, there was no improvement in her ability to swallow. I was then consulted to insert a peg or not to insert a peg, which brings us to a very emotive topic, and our topic of today, enteral feeding in the patient with advanced dementia. So before we get on to our actual topic, I thought we would just recap a few general important aspects in geriatrics, because these all impact on the decision-making process for these patients. So Professor Bernard Isaacs coined the term the giants of geriatrics as being immobility, instability, incontinence, and impaired cognition. What do they have in common? Well, they've got multiple causation. There's a chronic course. It deprives the person of their independence, and there's no simple cure for these conditions. Geriatric syndromes, which is what we deal with, are multifactorial health conditions that occur when the accumulated impairment of multiple systems render an older person vulnerable. The syndromes include the geriatric giants, as well as frailty, sensory impairment, multimorbidity, and polypharmacy. And unfortunately, these syndromes love company, and they often occur together. So older adults often suffer from different types of health conditions. There are those related specifically to the aging process. Then there are chronic conditions such as your hypertension and diabetes. And then there are the geriatric syndromes. And because of the complex interplay of these syndromes and that they often occur together, these patients often suffer from multimorbidity and multi-complexity. We then come to another very important concept in geriatrics, which is frailty. So frailty is basically an age-related decline in reserves that results from a reduced ability to recover from stress. And this loss of ability to withstand stresses is an independent risk factor for mortality, falls, and functional decline, and then obviously a loss of independence. It occurs as a spectrum from robust to severely frail, and it's very easy to move down the spectrum. So it's very easy to go from robust to being very frail. But once you're at advanced frailty, it's very difficult to go back to a robust state of health. In fact, it's impossible. Then the patient that we're talking about at the moment also has dementia. So it's just worthwhile recapping a little bit about dementia before we discuss our particular patient. So it's normal to become a little bit slower with aging. And it's even normal to forget a thing or two. But as you can see from this graph, it shouldn't impair your functioning in any way. And you can see over here that as you age, your cognitive reserve does decrease, but it never quite crosses that graph of where your activities of daily living are impaired. And that's how we measure whether there's functional impairment or not. So dementia is now called a major neurocognitive disorder. And according to the DSM-5, there has to be a significant decline from a previous level of performance in one or more of the cognitive domains. And there has to be interference with activities of daily living. And then obviously, once you've decided that there's dementia, you can decide what the cause is, and you can decide if there are behavioral problems or not. And you have to rule out delirium and any other causes that might present as a dementia. So globally in 2020, there were 75.6 million people living with dementia, and the prevalence is about 5 to 7% of the elderly population. But obviously it's more common as one ages. So at a 60-year-old, the prevalence is only 1%. But when you get to about 85 and older, the prevalence is as high as 45%. And the 2011 South African census showed that in South Africa, 2.2 million people had some form of dementia, but they don't specify exactly which kind. So this over here is just my favorite slide when we talk about dementia, because it's a summary in one. So dementia is a blanket term for a group of disorders. Alzheimer's dementia is the most common type, accounting for 50%. And each dementia syndrome has specific characteristics that help you make a diagnosis. But remember, our geriatric patients are very complicated, so there's often overlap, and you have to look for many different causes. But very important, as you can see on the top right of your screen, is that you have to look for other causes of dementia that may be reversible. And if caught early enough, you can cure the so-called dementia. For actual dementia syndromes, there's no cure, but there are certain medications that can slow the progress. Right, so now back to our patient and our dilemma, enteral feeding in the older adult. So why does not feeding a loved one cause so much distress? Well, food and eating play a major social and religious role in most cultures. And when a patient refuses to eat or can't eat, it causes a lot of distress for the family and sometimes for the patient as well. Then we have to talk about the swallowing process, which is remarkably complex. It involves multiple cranial nerves, multiple muscle groups, cortical and subcortical brain signals, and these all have to be precisely coordinated within a few seconds. The loss of swallowing happens late in dementia, and the swallowing in general occurs in 3 phases. I'm sure you all remember this: the oral, the pharyngeal, and the esophageal phase. And each phase in turn can be affected by certain disorders. So something like a stroke would usually affect the pharyngeal phase, while dementia affects the oral phase. And the patient can't coordinate chewing and initiating swallowing. So as you know, swallowing begins when the oral phase, with the oral preparatory phase, when the bolus is being prepared to be swallowed. And the oral phase is under voluntary skeletal muscle control. So you need the participation of an alert person. Then in the next phase, which is the pharyngeal phase, the tongue propels the food bolus down into the pharynx. And this is partly under voluntary and partly under involuntary control. And then finally, in the esophageal phase, there's a peristaltic wave of contraction that moves the food bolus through the esophagus, and this is under involuntary control. Acute confusion or delirium can impact on feeding and swallowing because of the decreased level of consciousness and the skill required to swallow. Then certain medications also have detrimental effects on swallowing, and a lot of our patients are given lots of medicines. So antipsychotics can cause Parkinsonism and dystonia, and then your antidepressants and benzos can cause drowsiness. And then even medications with anticholinergic side effects can lead to a dry mouth, which can make swallowing very difficult. So when this happens in these patients, the options are then either the use of artificial feeding tube, like a nasogastric tube, a PEG, a percutaneous endoscopic gastrostomy, or radiologically inserted gastrostomy tubes. And these are frequently being used without actual consideration of the suitability of the procedure and the patient. So when we look at a swallowing disorder, we need to evaluate the swallowing disorder to start with. And the goals that we're aiming for are to try and identify the pathophysiology of the disorder, how severe the disorder is, and then to determine the relevant and appropriate interventions. So our approach usually starts with an assessment of oral hygiene, just to look for things like a dry mouth, oral thrush, poor dental hygiene, and any obstruction such as dried food, just to show if the patient's been swallowing previously. Then the neurological exam is really important because we know that the cranial nerves 5, 7, 9, 10, and 12 all need to be intact when it comes to swallowing. Then we want to directly observe the patient while they swallow. So you give them a bit of water, and then it's quite useful. The speech therapist is the person to call for the next lot of evaluations, because they need to look at the patient swallowing liquids and solids and different consistencies and see if they aspirate. So unfortunately, some patients aspirate silently and they don't respond to aspiration with a cough, which is how we usually recognize it. So if you've got a high index of suspicion, these patients then require further evaluation, which can either be done by a video fluoroscopy or barium swallow to start. And then if you need a more in-depth look, you can use a flexible endoscopic examination of the oropharyngeal swallowing, which is called FEES, which the speech therapists do. Or you can do an esophago-gastroduodenoscopy, which I've never witnessed and I've only recently learned about. So just a quick run through of some of these concepts. Video fluoroscopy evaluates the oral, pharyngeal, and the cervical esophageal stages of swallowing, and the barium swallow examines esophageal function. With FEES, the oropharynx and larynx are visualized transnasally, while the patient swallows some food and liquids dyed with food colorant for contrast, and it provides information about mucosal integrity and laryngeal function. And then your esophago-gastroduodenoscopy is done by a gastroenterologist while the patient is sedated. I've never seen that being done personally. So now back to eating. So when we talk about eating, it's very important to note that older patients are very prone to malnutrition, and this is for a number of reasons. They have a decreased food intake. They're often cachexic because of multiple medical conditions, and there might just be age-related changes. The prevalence is 35 to 65% in hospitalized patients, which is horrific. But even more scary is that the prevalence of malnutrition is 15% in mobile outpatients. So those are people who are living very independent lives and are doing their own thing that you actually think are fine. So this just shows that screening for malnutrition is very, very important. And you can do it using a really simple tool. So the mini nutritional assessment has a couple of questions that you tick. I mean, you don't even need a BMI. You can literally just measure your patient's calf circumference and determine whether your patient is malnourished or not. And our patient is definitely very malnourished. I mean, you don't really need an MNA to tell you that. So now we have to consider inserting the peg, which is what they wanted us to do in the first place. But the decision is not actually that simple. You have to take a number of considerations into account. So you have to look at the patient preference, religious beliefs, ethical considerations, the prognosis, what the patient wants, what the family wants, and nutritional parameters. And obviously, if the patient is compos mentis, what they want is the most important. And hopefully, if they're not, they've had some form of talk to their family members about what they would want in case this sort of thing happens. So I find these decisions really difficult, and also you agonize over it because you don't know if you're giving the right advice or not. So I like to ask the following set of questions when it comes to help guiding my decision-making process, because I don't like a one solution fits all for every patient. Everyone's different, and you have to take a number of things into consideration when choosing the best course of action for each independent patient. So these are the questions that are really, really important. Firstly, does the patient suffer from a condition that is likely to benefit from enteral nutrition? Because if they don't, then there's really no point to it. Will the nutritional support improve the outcome or accelerate recovery of whatever condition the patient has? Will quality of life and well-being be improved by enteral nutrition? Do the benefits outweigh the risks? Are there sufficient resources available to manage a feeding tube properly? So, for example, certain old age homes won't take a patient who has a feeding tube because of the increased care it requires to look after these patients. So if a patient's going to be discharged from hospital and the family can't look after them, or they don't have a private carer, if they're going to go to a frail care that doesn't accept feeding tubes, there's really no point in putting one in because the care needs of the patient are just too overwhelming. And then the most important, of course, is what are the patient's wishes? And that's only if your patient is compos mentis and can make such decisions. So the aims of enteral nutrition are really, really simple. I mean, obviously, you want to provide sufficient amount of energy, protein, and macronutrients. You want to maintain or improve the nutritional status. You want to maintain or improve function, activity, and capacity for rehabilitation. You want to maintain quality of life, and you want to reduce morbidity and mortality. So that's really, really very simple. So enteral feeding is considered in neurological conditions where swallowing is affected. So things like dementia, stroke, and neurodegenerative conditions. But then there's some other conditions like esophageal malignancies and strictures and facial trauma, for example. So as with any procedure, because putting in a feeding tube is a procedure, you have to ask, do the benefits outweigh the risks? Because there's always a risk of procedural complications. However, with the PEG, there's a greater use of physical and chemical restraints, especially in your confused patients who keep on trying to pull their PEGs out. So in our patient, they wanted to use a PEG because of aspiration, but enteral feeding itself doesn't really protect against aspiration, which is what the problem was in that particular patient. So you also have to wonder if the indication is correct. And then because we're talking about whether the procedure needs to be done or not, we have to have a quick word on the medical F word, which you must never write in a patient's file because it causes a lot of problems. But medical futility is defined as any treatment that within a reasonable degree of medical certainty is seen to be without benefit to the patient. Or it can be when you use a treatment that's usually effective for that particular problem, but in this case, it's seen as ineffective with regard to the clinical problem that it would normally treat. Futility is very ethically controversial, and there's no unanimous opinion of what actually constitutes futile. So often there's a lot of disagreements between the treating physician and either other physicians or the family or the patients. But when it is used, it's often used to justify the request by patients and families to not pursue certain treatment options. So depending on the situation you're in, it can be a very useful option. So now, because feeding, it's such a difficult decision of whether to insert a feeding tube into a patient with advanced dementia, the American Geriatric Society has offered 5 position statements. So there's a little bit of evidence to back up your decision to not put one in if you don't insert one. So they say that feeding tubes are not recommended for older adults with advanced dementia. Instead, careful hand feeding should be offered. This option is as good as tube feeding for the outcomes of death, aspiration, functional status, and comfort. And it also allows the patient to socialize in a conducive environment. So just to note, in case you think that the American Geriatric Society is advocating for starving patients, it's really not. They're just saying that using careful hand feeding is just as good to achieve adequate nutrition. Then the next statement says that efforts to enhance oral feeding, such as altering the environment or using individual-centered approaches, should be used. Tube feeding is actually viewed as a medical therapy, so it can be accepted or declined by the individual surrogate decision maker if they have such a decision maker. And then in long-term care settings, so like old age homes, you have to understand any previously expressed wishes of the individual, which is why having conversations with patients before they reach the stage of advanced dementia is so important. And then when you in an institution, you have to promote choice and endorse shared informed decision-making so that everybody's on the same page. So just a bit of a study to show that I'm not talking rubbish. The Cascade study, which was the choices, attitude, and strategies for care of advanced dementia at end of life, followed individuals with dementia over an 18-month period. Of these patients, 85 of them experienced swallowing difficulties and had swallowing involvement. And when there was swallowing involvement, the 6-month mortality was 50%. And it was found that eating difficulties and aspiration pneumonia formed part of the natural progression of disease and indicated a transition to end of life. So a transition to palliative care, basically. Then the European Society for Clinical Nutrition and Metabolism also recommends against the initiation of feeding tubes in patients with advanced dementia. They consider enteral nutrition as a medical treatment rather than basic care, and therefore it should only be used if there's a realistic chance of improvement or maintenance of the patient's condition and quality of life. So let's get back to our patient. What happened to her? Well, her daughter was extensively counseled. She realized that her mom was dying and didn't want to prolong her suffering, so she decided against the PEG and opted to take her mom home. She was instructed on very careful oral feeding and spent precious time with her mom at home, and her mom died shortly thereafter, but it was expected. However, not everybody was in full agreement of this treatment plan, and the speech therapist, who had done an excellent job in helping our patient, was not very impressed because she really felt that a feeding tube was needed in this case. So sometimes deciding what's actually beneficent to our beneficent to our patient is very difficult. Not all situations are so clear-cut, and sometimes you need to have multiple conversations and really agonize over the decision you make. And then, just when you thought that this talk was over, I'd like to introduce you to Mr. RG, who's a relatively new patient of mine from last week. So he's an 80-year-old man who lives with his wife and daughter. He lives with his wife, but his daughter's actually nearby. She doesn't live with them, but she's there all the time. So he was high functioning until a year ago, when he started to have this functional decline, which they couldn't really explain, and he needed help with all instrumental activities of daily living and even some basic activities of daily living. So the family took him off to a doctor who diagnosed him with benign prostatic hypertrophy and inserted a transurethral catheter, but didn't really say anything about the functional decline, and then sent him home again, and he just got worse and worse. And then over the last 2 months, his family noticed that he'd become a little bit more confused than usual. So he was still walking, although his gait had changed, and he'd become very slow and shuffly. And he tripped one day at home and he sustained a neck or femur fracture. So they brought him into hospital and he was admitted to the orthopedic ward, and they inserted an intramedullary nail for him. I didn't know this man existed until about day 7 or 8 after this intramedullary nail insertion, when I was consulted because he had aspirated and he was looking really sick. So when I went to see him, I found an extremely frail, sarcopenic man who had a very soft voice and a tremor. And while I was seeing him, he was trying to drink some water and he had a sip and he was coughing and coughing. And I looked at him and I just thought he had Parkinson's disease, especially with his very hoarse voice, this history of the slow shuffling gait, the tremor, which sort of gave it away. So I started him on some Cinemet. Anyway, at the same time, we consulted the dietitian because he had lost a lot of weight, and the family's main concern about him being in hospital wasn't really his prolonged stay, but more that he had just lost so much muscle mass and he was basically wasting away while lying in the hospital bed. So the dietitian came and the speech therapist also came, and they did a swallow assessment and found that he aspirated inconsistently, but a lot worse with liquids. So they put in a nasogastric tube, which he duly pulled out. They put it in again, he pulled it out again. So they thought that maybe it was uncomfortable for him. So they got him a nice thin flexi flow, and they asked him to please leave it in, although he's a little bit demented, so it was a bit difficult. Anyway, he didn't like the flexi flow either, and he pulled that out as well. And the orthopedics threw their hands up in despair, and the speech therapist said, no, he needs a PEG. So I had to have a chat to the daughter, and his daughter was visiting him. And even though they had told her that he mustn't eat anything orally, she had been bringing him some food and she had been feeding him because, I mean, she knows what her dad likes, and she realized that he swallows more solid foods a little bit easier. And he didn't aspirate when she fed him. So I had a discussion with her about a peg, and I asked the patient as well, and neither of them were very keen on peg feed or on a peg tube. So just a little word on swallowing problems in Parkinson's disease, because it's also really common. It affects up to 30 to 52% of patients, and in the later stages of the disease, up to 80% of patients, which is huge. And these swallowing difficulties impact on quality of life and morbidity. And unfortunately, the biggest problem is that they often go unnoticed early in the stages of the disease. So when you can do something to help the patient, often it's too late. So with Parkinson's disease, all the phases of swallowing are involved because of changes in the striated muscle that are under dopaminergic control, and because of smooth muscles that are under autonomic control. So the dysphagia results from multiple mechanisms. The oral phase is due to the cardinal symptoms of Parkinsonism that you all know. So the tremor, the bradykinesia, and rigidity. Then the pharyngeal dysphagia results from delayed oral delivery, uncoordinated striated muscles, and reduced somatosensory stimuli and abnormal autonomic function. Then you get degeneration of the dorsal nucleus of the vagus nerve and the esophageal myenteric plexus, and this causes both the pharyngeal and esophageal dysphagia. Just to note that disorders of swallowing and gastrointestinal motility are the most prominent non-motor features of Parkinson's disease. And just remember that gut motility is controlled by extrinsic input from the dorsal motor nucleus of the vagus and the paravertebral sympathetic ganglia, and through local reflexes mediated by the enteric nervous system. And all of these are impacted in Parkinson's disease. So all of these contribute to the gastrointestinal dysmotility. So in this patient, the speech therapist was very keen for a peg. And I told you that before that there's no one approach fits all. So in this case, I was also actually quite keen for a peg. And this is because this patient was very sarcopenic. He was underweight, malnourished, and aspirating, and he didn't actually have advanced dementia, and his end of life wasn't coming as soon as in the previous patient. And I thought that in this case, maybe the peg could be used as a temporizing measure while we give him his medication and hope that his swallowing improves. I mean, the data is inconclusive as whether Cinemets or even deep brain stimulation actually improves swallowing, but it does in some patients, and it's definitely worth a try. So obviously, while these deliberations were ongoing and his daughter was deciding and he was deciding, and there was a lot of back and forth, he received careful hand feeding with a thicker food consistency, and the family brought him all the food he liked, and he was able to eat better and aspirate less. But despite all of this, all these conversations, the family still said no to the peg. And I mean, you can't force somebody to do what they don't want to do, even if you think it's the right thing. So he didn't get a peg either, but for different reasons. So just remember, sometimes it's easier to recommend a non-beneficial procedure than it is to have difficult end-of-life conversations. So just a few take-home messages. When older people who are very frail present with pneumonia, always consider aspiration and assess their swallowing. Then remember that malnutrition is very common in the geriatric population, and it's very easy to screen for, and then at least you can do something about it. Enteral feeding is not recommended in advanced dementia because swallowing difficulties are a natural progression of the disease and indicates a shift to end of life. And just keep in mind what your end goal is and what you're trying to achieve. So are you aiming to improve quality of life, or are you aiming to extend quantity of life? And that is the presentation for today on enteral feeding in the patient with advanced dementia.